This is Group C4's COVID-19 Challenge, Communication and Safe Transfer Between Nursing Facilities and Hospitals. The project aim is to address the continuity of patient information during one-way transfers between nursing facilities and hospitals. The Institute for Healthcare Improvement has said that poor communication of medical information at transition points is responsible for as many as 50% of all medication errors and up to 20% of adverse drug events in hospitals.
Over 25% of nursing facility residents aged greater than 65 years have had at least one ED visit in the past year, with an average of 1.6 visits per resident, many having repeat visits throughout the year. A study of 100 NF transfers demonstrated that in 32% of transfer patient information for the HPI could not be obtained from the patient, the NF transfer paperwork, or the NF personnel. Another study of about 500 NF transfers found an information gap of about 85% in the transfers, which included reason for transfer, baseline cognitive function, vital signs, advanced directives, medications, ADLs, and mobility.
Some of the factors affecting these errors can include doctors not knowing or not being familiar with nursing facility residents, the care home staff's lack of training and high workload, and also lack of communication between the care home, pharmacy, and practice. And also, standardized communication between nursing facilities and hospitals can improve the transition of care. A systematic review in June of this year showed that 8 different interventions involving transfer forms and checklists improved the documentation of critical information. Also, Pennsylvania does not have a standardized transfer form now currently, but the state of New Jersey does, and that was implemented in 2011.
Our proposed intervention consists of development of an EMR to EMR bridge accessible via quick response codes that when scanned will pull up a patient's targeted health information, pertinent details for safe transfer, and a comprehensive COVID history. Such technology would directly address communication mishaps between different institutions that have been exacerbated, especially during the COVID crisis. A similar approach has been successfully implemented in Fujian, China, to monitor the population's COVID status based on this study. Required components of our intervention include development of a mobile app, use of a web-based platform such as Windows, use of an inter-EMR manager such as Citrix as widely used in many hospitals. We plan to pilot our intervention at Maplewood Manor with the distribution of QR code bracelets to all residents linked to our EMR network.
The transfer form we have envisioned for this project would be a working document in the patient's EHR. This document will be pre-populated with data as it exists in the EHR, but will also allow for free text areas as needed to elaborate the nuances of the patient's current situation requiring transfer. This document will serve as a universal form that presents a clinician with a snapshot of the patient's most vital information. This could be the initial bridge between the transferring and receiving facility's EHR. This would limit the need to navigate a lengthy paper chart or an unfamiliar EHR. A quick review of the form reveals the necessary demographic information, including power of attorney and code status, as well as any neurocognitive and/or physical deficits. It is also including relevant histories and a quick summary statement of the patient and need for transfer. In COVID times, it will include a screening section, but can be expanded to include any other isolation precautions or new threats as needed.
De-identified data will be collected at Presbyterian ED for all UPMC nursing facilities for 6 months. Once similar nursing facilities have been designated as controls, we will analyze the differences in medication discrepancies, inappropriate interventions related to code status, and number of COVID exposures.
In summary, our proposed intervention would provide an up-to-date, accurate patient record that would reduce the risk of medication errors and prevent interventions that are not in line with a patient's goals of care. Barriers we anticipate include the time to train staff and to document, also the process of adequately protecting PHI across different EMRs, which would require some level of capital investment.
Future directions include expanding this to different aspects. This difficulty obtaining history is not unique to nursing facility to hospital transfers and could be expanded to different types of facilities or more broadly to patients living in the community. As well as addressing social justice, our current system requiring the ability to accurately and verbally communicate medications and medical history can be difficult for patients with cognitive impairment, sensory impairment, as well as those with poor health literacy. Black Americans may also be more at risk of medication-related errors. This tool could address ageism, ableism, and racism that's endemic in healthcare.